Hi to everyone. I'm Dr. Ramiro Cabrera. I'm here with Katie Boyce, and we like to make this video about Katie's work. Let me introduce first. I'm Dr. Ramiro Cabrera. I'm the head surgeon, or one of the head surgeons here in the global group in Tijuana, Baja California, Mexico. And I'm here with Katie, which is one of my best friends now in the endometriosis family.
My name is Katie Boyce. I am a board certified patient advocate, endometriosis patient myself, and a chemist as well.
Katie, please let us know what made you do endoverse love.
So, I had my own journey with endometriosis, and I was able to finally access the necessary proper care. My sister as well had endometriosis, and the same story for her. And I realized, there's a significant need for that kind of assistance. And so, and I also brought my background in chemistry into it by wanting to do more of a scientific communication as well. So I like helping patients and guiding them to the proper care, but also taking complex topics and research about endometriosis and trying to break that down into more understandable language.
What do you think that these patients suffer as well, or other symptoms that are common that you can see in this type of approach for patients to you?
Yeah, so I am constantly discussing endometriosis with so many patients, primarily because so many feel alone. And they reach out to me online and just say, hey, someone told me that I should reach out to you. But what I do is, I kind of go through, what my journey was and what my sister's journey, and so many of our, all of our collective journeys are very similar. And so I kind of go through that with them and say, maybe endometriosis is something you'd want to investigate. They're told they have recurrent UTIs.
About this, do you think that there's the adequate information around for patients that suffer from endometriosis to get really well educated on?
No, we don't really have any sort of like centralized place for patients to get information because misinformation about endometriosis is so rampant, right? Yeah. Endometriosis research is significantly lacking for a variety of reasons, and because of that, that translates into misinformation, incorrect information. So a patient, they might Google endometriosis and it'll just say a few classic symptoms that don't align with them. So they say, oh, well, I must not have that. And then they get misdirected. So we definitely need a better way to, improve research, of course, but then make a more comprehensive, better like understanding that can be disseminated to, larger medical institutions that people can trust, and just honestly, just a comprehensive place where patients can go get accurate information because it's so fragmented right now.
Yeah, and the most important part that even though there's like endoverse blog or many other like sites for endometriosis patients that can be welcome, and also to give information and try to share information about high quality treatment. Even though there's this type of places, by shame, we have 200 million. So you cannot approach to 200 million women. I know that you have seen patients from Canada, US, and many other countries. What do you think about the healthcare systems in these two countries that obviously they have first world countries even with healthcare? But like right now in Canada, a patient with endometriosis in Canada, how is she being approached, or what's their expectancy about the disease?
So typically, and I talk to so many patients in Canada, and the story, unfortunately, is always the same. Yeah. They, surgical wait times are reprehensible, and surgery is not really ever provided as an option. So, and as we know, endometriosis needs to be approached from so many different ways, and for, I would say, a large majority of us, surgery is absolutely necessary, and it needs to be, once we empower the patient, it needs to be up to the patient what they want to do from that point on. And that's my job as a patient advocate, is to make sure that they know every single avenue available to them so they can make the informed decision. So when I'm speaking to patients in Canada, they're not being given the surgical option. And I hate that an option is being taken off of the table for them. So, they wait a few years just to finally get to a surgeon, and then you're worried, was I even getting the best type of surgical care I could possibly get? In the United States, the limiting factor definitely tends to be financial. So most of our, our higher volume surgeons that tend to have the better track records, a lot of them are out of network from our traditional insurance. So And that's because of reimbursement rates, and it's very political. So those surgeons, there's no incentive for a surgeon to go into endometriosis surgery. Reimbursement's horrible. It's really difficult work, and there's just no incentive. So, they're two different things happening in the US and Canada, but they're definitely limiting factors for accessing care.
About this type of treatment, do you think that all of the patients that are having endometriosis may encounter excision or have a viability to get excision?
Oh yeah, absolutely not. It's because it is a more difficult process. There's a lot more risk to it. Because of that, it's difficult for a patient to find a doctor that'll do that. And a lot of patients don't even know it's an option. You go to your OBGYN and either the OBGYN doesn't even know that option exists, or they don't believe in it. They'll say, oh, it doesn't work. It's no better than what I just go in and do. And so because of that, there's, even if a patient could financially access it, they're not even being told it exists.
Yeah. What do you think that your role as an advocacy should be of explaining patients what true multidisciplinary approach during surgery and also after should be?
Right. So we hear a lot once we learn about excision and we figure out, okay, this is what we should be expecting during surgery. We hear multidisciplinary a lot. And so that means maybe we need to have a colorectal surgeon assisting for deep bowel disease or a resection. Sometimes patients will have thoracic endometriosis, and in that case, you have to have a cardiothoracic surgeon there. So that's like the multidisciplinary in the OR. But then there's a disconnect because a lot of patients, when they hear multidisciplinary, they think that means multidisciplinary care outside of surgery afterward. And a lot of surgeons aren't making that distinction or explaining that to patients. Endometriosis is, it's a variable disease, and every patient may experience their disease a little bit differently. So, someone may have complete resolution of pain after their surgery, but some patients may not, and they need that multidisciplinary follow-up care, whether that's going to be working with a registered dietitian because they have continued, bowel symptoms, or maybe they need, they need that. Yeah, and they need the pelvic floor physical therapy. Some patients need to see someone who can help them with their hormones. Just because the disease, we don't know what has done to maybe the ovaries or surgery's done. So that is what, the standard of care for multidisciplinary should be after surgery.
What have you encountered after full excision? How's your quality of life, and also how have you seen the quality of life of patients that has gone through really proper care?
Right. So, I try to explain to people, I had my surgery 6 years ago. I had 2 surgeries within 6 months. And, when we do that, recovery is even harder. That's a lot of surgery in a short amount of time. And because, my operation is going to be different from another endometriosis patient's operation. So it took a while, and I really wish I had been told before surgery how long the healing process can take. That was an expectation I was never really informed about, to the point where it would have been helpful to know. I was told, give it 6 months or however long, but I had other issues arise that I didn't even know could happen. And so for me, it took, seeing somebody for, my hormonal health, and then pelvic floor physical therapy, which my doctor, he was great about that and told me that will be necessary. And so it really was just a lot of long-term, what are my residual symptoms and how do those need to be addressed? So for me, I had to tease through all of that on my own. And hopefully the goal is, with advocacy and then an actual center that can do this multidisciplinary care afterward, is that the patient doesn't have to take the same journey I did, where it's finding it all out on my own. So now someone can be like, hey, Kate, I'm having these symptoms 6 months after surgery. I'd be like, well, I kind of had that too. Maybe I know a great registered dietitian that happens to really do well with bowel symptoms. Having that type of access and knowledge, advocacy, and then having a center that can, keep that all in one place. That now my quality of life is exceptional, right? I didn't even know that it could be this good with having endometriosis, and it seems like a bad dream sometimes when I look back on that. But I also know the journey to get here to where I feel today. It's been 6 years, and I would say the first 2 years after surgery were not the easiest, but I'm glad that I didn't give up on my body. And I trusted that if I gave it, the right time and the right treatments, that it could come along to being better than I ever thought was possible.
So thank you, and also as I was telling Nancy before, well, thank you so much because of your work, you're changing the quality of life of many women, and you're reducing the what we call the diagnosis curve. So we're trying to avoid, in first world countries, the time to get into diagnosis 7 to 10 years. That doesn't mean to get treated. And some patients will stay the whole life with chronic pelvic pain because they're misdiagnosed and mistreated. So we're trying to avoid that. Even though endometriosis will never kill you, it totally affects the quality of life. Some women even when we talk about endometriosis and definition is a benign disease, they tell me it's never a benign disease because my quality of life is totally ruined. So even I cannot die, but what's the meaning of living if you're always in pain?
Yeah.
So thank you very much because of your work, you've been touching these few women. Obviously, not me, not you can treat 200 million,
Right.
but obviously one by one will get a little bit better.